it, Neil.
I've just started 3 seconds ago.
Okay, that's great. Thanks very much. So a plea again as usual to remain on mute throughout the session, just to minimise background noise, unless you are the person who's going to be speaking. And use the hand up function if you want to ask a question. That way we can make sure people are heard and get brought in with the question at the right time and in the right order. And if you want to view the speakers who were talking rather than the slides, just click on the pictures at the bottom of the screen. It'll take the slides off and you'll be able to see people's faces, and the person speaking will be in the middle of the screen usually. We will be having a break formally at 3 o'clock to give people a chance to refresh and get a drink. But if you do feel you need to have a break any other time, feel free to do so. This is a meeting that's, an important meeting, but we want people to feel relaxed and able to join in and be comfortable while they're doing so. So just to formally thank you all and welcome to our second online event. I think our first one felt really good. I was quite pleased, but I was very pleased really at how it went, managing to be able to talk to as many people and hear as many people's voices. It was great to hear that. And thank you for everybody who completed our last survey. These are really important. They help us to inform the future agenda items. They help us to think about the way we're going to structure the meetings and how we want to engage more readily with yourselves in a way that's going to best meet your needs and your requirements. I'll ask you again as well to complete the evaluation at the end of this session. There'll be a link posted in the chat, but we'll also be sending that out, making it easier available for those who can't access it in the chat box. And as I've said already, this meeting has been recorded. So if you don't wish to be recorded, please switch off your camera and just show your initials on the screen. And again, don't forget you can use the chat function to ask any questions. I need to say up front, I need to leave the meeting at 2:30, unfortunately, for half an hour, but I will be back at 3 o'clock. And if to have a chair, because I know the speakers on the agenda are planned at that time period. Neil McKnight will take over the chair during that period, should we need to do that. Any questions before we start on the formal agenda? People happy with the approach for today? Yeah, okay. So feedback from the last meeting we had on the 5th of October was people had a preference to see fewer slides and more of the speakers. So what we're going to do then is stop sharing the screens when we come to the questions, follow any of the main presentations. Again, recognising it's better talking to a face rather than just to a screen with the presentation on it. And I think that was a point well made we take on board. And we're trying to reduce the number of slides where we can and make them more easily readable for people. We did receive a request for lay members to be invited to the next meeting to provide their perspective on the COVID outbreak for a Newcastle Gateshead CCG involvement. And we will try and schedule that for our next meeting in December. And we'll work with our advisory group to make sure that agenda meets everybody's needs. So that's a helpful comment to make. And I think that our lay members actually have a lot to offer in terms of the support for this group. They really are keen to understand what we do and how we work. And another plea was to help us contact PPGs and the practices so that we can identify all the PPG leads. That's the practice participation group leads. And can you just email us any of the names you know to the email address shown there in the bottom of that slide? It's a generic address, so we'll pick that up. It gets manned every day, and we'll be able to have a more comprehensive list of practice participation groups. We're really keen to connect between this group and those practice participation groups, makes the discussion meaningful and connected across where we can. I can see someone's hands up. Steve, your hand's up. Do you have a question? Steve, you're on mute. Steve, do you have a question, or is your hand up by mistake? Okay. We'll move on to the next slide, please. So I'm going to talk a little bit about the engagement update and what we've been doing over the last short period of time, and when I've done my piece, we'll ask Dan to come and give his update on the primary care network engagement involvement out in the West Gateshead. So a big piece of work that's going on at the moment is this co-production of a community transformation plan for mental health services across Newcastle and Gateshead. But what we are doing with that work is listening to people's views, engaging with people, and understanding what people require, and looking to develop a model specific to Newcastle and a separate model specific for Gateshead. It won't just be a co-offer across. The model will be based on what we hear and what each of those geographies require to meet the needs of their populations, and the different constitution of the populations will be adhered to. The core service would be the same across. It'd be where we need to have anything specific in each of those to address those needs. The intention with this is to make mental health services more accessible in the community, to make access to crisis support more accessible early on and early, where people can be seen more quickly, saving them to have to be escalated into more mainstream and more complex services. Trying to as well to avoid people needing to attend emergency departments at the RVI or the QE, and maintaining people in a much more stable environment in the community. The services will be transformed to what you know now. We'll be still having obviously community-based teams, but we're making them very specific around meeting the agenda of people in the community. Looking at talking therapies, making those more accessible, doing things like counselling services and those kind of things, really just so it's much more easy to get into mental health services and get what's required out in the community. With engagement plans with children, young people and families, and support available about what helps during the lockdown. And this is specific at this point in Gateshead, but I think what we need to do is learn from that and try and do the same in Newcastle. It's important that we understand the impact the lockdowns had, particularly on children, young people and their families. We've heard anecdotally that it's been really difficult for people. It has an impact on the mental health, not just on adults, but particularly we've had issues with children and young people where mental health has been affected and they've needed to seek additional support. There has been some additional support put in, and we just need to make sure we sustain that support in a timely manner going forward. So it's important that we learn actually from the children, young people and their families and don't make assumptions. You remember the little orange book? We had presentations from Kate Cushing, one of the GPs who worked with us at the time, who wrote the little orange book that was about common childhood illnesses to help people in the community to manage and care for their children without needing to go to see a GP or to the hospital. We're extending that now, calling it just, very anecdotally, a big orange book, which has been based and targeted for teenagers in year 7 at school upwards. And we're currently working with the children and young people in that age group to see what it is they need in that big orange book. The big message coming forward again is around mental health support, mental health and well-being, and how they've managed to access some of those services. And they're keen to understand broadly how they can access health services themselves confidentially and use them to meet their own needs. So that is work that's in progress now. We'll keep people informed of that. We'll bring something to the group as we've got something to share in case anybody has anything they want to add or comment on. I think it's a really important piece of work. The Little Orange Book, if people remember, it's almost gone national. Well, it's gone national really. In this country, we get requests from far and wide. In the UK, Scotland and Wales, we've had where people wanted to use the Little Orange Book locally. We've supported that because it's important that we share the things that we've been good at and managed to do, and then with a similar approach with the Big Orange Book. The next slide. I'm going to hand over to Dan now, who's going to talk about the Outer West Primary Care Network.
Thanks, Chris. Yes, my name is Dan. I work for Involve North East, and we do patient care and public involvement work for Newcastle Gateshead CCG. And we were reported to do some work for Gateshead Outer West Primary Care Network. If you're unsure what a primary care network is, they are basically networks of GPs covering approximately 30 to 50,000 patients, and they provide a structure for GPs to basically develop localised services in response to patient need. So Gateshead at West Primary Care Network is one of 12 across Newcastle and Gateshead, and it consists of 7 GP practices covering a patient population of approximately 31,000. And as you see there, the GP practices included Bladen, Chopwell, Crowcrook, Grange Road, Hollyhurst, Oldwell and Rowlands Gill. Next slide, please. So a key priority for Gateshead at West Primary Care Network is digital enabled care. Now, work had been underway prior the pandemic to map digital services and pathways, but when the pandemic hit, this resulted in an acceleration of plans and a refocus on ensuring patients were able to connect with and be supported by their practices. Online services provided new way of consulting in general practice with the use of text and video technologies, allowing you to speak to health professionals. And some advantages have been identified over more established ways of consulting face-to-face. So Gateshead at West Primary Care Network took this opportunity to ask us to engage with their patients and stakeholders to basically understand how people have responded to this shift and this move to a more remote world. We're just kind of in the middle of that. We've just come to the end of the engagement phase, so I can't provide information on all aspects of it and some themes and issues that have come through from the stakeholder engagement. So as part of the engagement, we've spoken to 222 patients via an online survey and undertaken 24 interviews with patients who were not accessing service digitally. And we spoke to 13 stakeholder organisations across Newcastle and Gateshead. Those organisations highlighted a number of concerns, which I can share with you, including the differences in age ranges of people, how comfortable people are in accessing digital services, with them generally agreeing that younger generations are more comfortable to access services online, although there are plenty of exceptions to that rule, with lots of older generations being quite tech savvy. They identified some real issues around IT equipment and the available access to smartphones, tablets, computers, and how compatible they were with current systems. As you may already know, if you have an older style smartphone, that can impact how you can access services. They also highlighted issues on internet connections and data. So if you're in a large house and you share an internet connection, this can really hamper your ability to have video conferencing. Or if you have a very low data plan, that can also impact your ability to use online services. They highlighted a fear of the unknown. So they highlighted that if people hadn't used something before, they were quite worried they might break it. They also highlighted issues and a worry around sharing information that could later possibly lead to you being scammed. They also highlighted issues around capacity to use online services and people's literacy levels. And they felt that when it came to some groups, their ability to use tech services or e-consult forms when you contact your GP was limited, and they weren't able to really convey the issues they felt, which could impact on the treatment they receive. And for anyone that has English as a second language, and the difficulties they would face in using text to actually communicate with someone. And finally, they highlighted a real issue on lack of information about what to expect and what to do, and that there was a lot of confusing messages out there, and actually in some cases highlighted members of their communities that they knew had actually not gone to GP services with the expectation they'll wait until things return to a normal and they'll just get a face-to-face consultation, really highlighting that people are actually maybe putting their health at risk because they're not comfortable with the current way of working. Now, as I said, that's just the highlights from the stakeholder engagement. The patients are still getting analysed as we speak, so I'm quite happy later on, a later date to come and we discuss the report in full. But does anyone have any questions regarding where we are at the minute?
Everybody okay? I can see one hand's gone up. Jean?
Is that okay? Can you hear me?
Yes.
Yes, we can hear you now, Jean. That's great.
Yeah, my concern is around the people who generally need what might be called the sanctuary of the consulting room, who need that quiet peace, who don't feel happy talking to a screen or to a text machine, and so they sort of, I was going to say, the abused, the worried, the depressed. I would be interested to know how that's going to come out of your survey.
Yes, that was highlighted within some of the discussions with stakeholder groups. Some real difficulties of finding that quiet space within a large house, potentially if you have a large family or if you're sharing that house with other members. it was particularly raised when it came to, say, asylum seekers. If they're in large multi-family houses, and there's a real difficulty of finding that space. So that's been highlighted within the report and will be highlighted. So yeah, it is a concern that has been raised.
And it's also with like abused women finding that sort of sanctuary. They could go to the doctor ostensibly with a sore throat, and have that privacy. Whereas, you know, if you just ring up and say, well, actually, I've got a sore throat, they wouldn't get that face-to-face appointment that is genuinely what they need. Yeah,
I agree. I think there's been quite a few media campaigns as well regarding this and the use of certain body language to try and convey issues you might have within your own private residence. But yeah, you're completely right. There are some issues that need to be worked out. There's issues around how people communicate in terms of their body language as well. So I think there's some things that are recognised, and that's one of the things that has been recognised. So hopefully what they can do is, as they look to develop the service, they can really reflect the need and look at certain ways in which they can help people convey those messages in a way that allows them to keep sort of that sanctuary within their own space at home.
I think in terms of domestic abuse, we've become aware there's been an increase in domestic abuse during the lockdown period, and are trying to make services much more accessible for women and for men who are in that situation. And there'll be lots of media campaigns going around just as we speak now, starting to kick off, to make sure people can see where they can get access to services in a safe and confidential way that wouldn't be shared. So it's over and above what we'd offer in GP practice.
And just one more thing is, I had a friend who was a GP, and she used to call it the door handle moment, when people are just about at the door and they say, oh, by the way, doctor, I've got a lump, or something like that. That is a worry.
No, I think you're right.
That's been highlighted within a few organisations where they've seen a bit of a dropout from service users, where perhaps it's very easy to drop out of a Zoom call or a text call. While if you're there and you're at a place, it's a little bit more difficult. So it means you actually have to be followed through with accessing that care. So yeah, it has been recognised, that door handle moment.
Okay, thank you.
Kate, you've got your hand up.
Hi, yes, thanks, Dan. I was just wondering, given that you're presenting this here, whether or not this is also being shared across all the primary care networks, because I'm presuming that what you're finding isn't particularly unique to this particular PCN.
Yes, that's the hope. Obviously, the PCNs encompass groups of GPs, but when it comes to topics such as this access to digital services, this can be shared, and we hope that it will be shared across all PCNs across Newcastle and Gateshead. I believe the information coming back isn't just locally to Outer West Gateshead and will be useful for all PCNs. So yes, I believe the PCN are looking to share it. So yes, hopefully it will be shared with all the PCNs and they can take forward the suggestions as well.
Sorry, can I just ask something else, or say something else really? I think doctors are working very differently, but going back to what was said by the lady before me, I do think there is an issue with the person. So let's say you start treating something that's going on with the knee, whereas in fact it's all coming from the back or the hip. You know, the musculoskeletal system might present things that talking to the patient won't establish. So I'm just wondering really, because I know Newcastle Trust, for instance, has put lots of things online about what to do with musculoskeletal. But then, you know, somebody starts doing, I don't know, exercises for their hip, but it's something else that's wrong. And because it's presenting in the hip, you know, they're feeling it in the hip, they could be doing themselves more damage. So I am just concerned about it in clinical diagnosis sense.
Yeah, I don't.
Yeah, sorry.
Go ahead, Chris.
No, you go ahead, Dan. Sorry.
I would say from my discussions with the PCN and their kind of approach is that this would never be seen as a complete replacement. At the minute, it's a sort of a needs must, that this must be the way, kind of the way forward. I think what they're trying to develop it is that it becomes a legitimate partner towards more face-to-face and those sort of traditional ways. So I think you are right, there are limitations to doing stuff digitally, but currently we are just hamstrung, I think, by the lockdown and the measures in place. Because you're right, there are things that can't be picked up. You can't pick up when you're speaking to someone how they're wobbling their leg or picking their finger or something like that, where body language would be people to see that in a face-to-face. So I think at the minute, they're doing what they can to make sure people can access support, but I think they're aware of the limitations.
Yeah. Nothing to add. That's what I was going to say, Dan. Sorry for interrupting. Cynthia, you've got your hand up next.
Yep, hi. Just to let you know, in terms of engagement, we're working with Newcastle Primary Care Networks to undertake an engagement programme. Little similar to yours, Dan, not looking totally at digital technology, but others. So it'll be interesting for us both to share that information together. Yeah. That would be excellent.
Certainly, yeah. I think the PCNs are welcome anyway to kind of develop the service they can do to reflect the needs of the patient. So yeah.
Can I just say, ironically, Healthwatch Newcastle did do a digital consultation exercise about 3 years ago, Crossline, and I was looking at it because I actually wrote it and looking at it, and some of them are still very similar, and we can relate to them. We can relate to the current situation with it, so it's also worth looking at that one as well.
Yeah,
perhaps Cynthia, you could share that with us, because that would be useful to have a look at that.
Yeah,
yeah, it was through national NHS, but we worked with Health Watchers, or I led Health Watchers across the country, and some really useful information.
Good. Yeah. That would be great, Cynthia. Thanks for that. Any other questions from anybody else before we move on? Okay. So the next slide, I think I'm going to introduce Pauline. Is that right? Yes, it is. I'm going to introduce Pauline Punton, who's the lead specialist social care worker at Newcastle Council. Pauline's going to talk about the care homes and what support we've been offering and what's happening in the care homes at the moment. I will be leaving the meeting in about 10 minutes, so I'll just dip out. I won't say I've gone. You'll just see me disappear off the screen. But I will be back by 3 o'clock. Thanks.
Right, thanks for that introduction, Chris. Yes, good afternoon. I'm Pauline Punton, lead specialist from Newcastle City Council. Obviously, we've been doing a lot of work with the care homes in Newcastle via Collaborative Newcastle. We have 46 older persons residential care homes and 7 specialist homes across the city, where we can support up to 2,500 people. Now, obviously, what follows in the presentation provides an overview of what's being done to support residents and staff to be as safe and well as possible in terms of both their mental and physical health. Next slide, please. So Collaborative Newcastle brings together the local authority, the CCG, the NHS hospitals that you can see on the strapline banner at the top, primary care partners alongside our care home providers to work together to meet current and future challenges and to deliver our enhanced care in care homes model. This group has been working together since the pandemic to understand, prevent and respond to COVID issues experienced by care homes in the city. There's also the care home wraparound nursing support teams that I work very closely with. Now that means that each care home is aligned and named clinical lead, GPs who can provide advice, guidance and respond quickly to issues as they emerge. There's the enhanced infection control training and support for care homes. Now the care homes across the city have been offered the training in infection control, which a lot of them have taken up that training, with the specific focus on COVID-19. An infection control lead works in close partnership with the homes and ourselves to embed infection prevention and control practice and to resolve issues proactively. Next slide, please. So Newcastle's COVID control plan. So the Newcastle COVID control plan was published in June and describes Newcastle's collaborative approach to preventing COVID outbreaks in the city, including care homes. We have established outbreak control pathways for both staff and residents across the care home sector. There's the care home testing. So care homes across the city complete whole home testing for residents and staff. Now that testing is weekly for staff and every 28 days for the residents. This will hopefully prevent COVID-19 outbreaks, detect infection outbreaks at the earliest opportunity, and where we can rapidly respond to contain the virus should an outbreak occur in a care home setting. There's also the whole home flu vaccination programme. So that programme's delivering free flu vaccinations to the residents and staff across all care homes in the city. It's well underway and obviously plays a key role in helping to protect the health and well-being of people who receive care and social care staff as we approach winter, as we all know, what the winter brings with it. So hopefully everyone, the majority of the flu vaccinations have taken place and it's well underway. Next slide, please. The providers have had some financial support. Obviously, there's government infection control funding has now been extended until March 2021. The financial support, which may be used in various ways, for example, ensuring that staff who are isolating in line with government guidance receive their normal wages while doing so, limiting staff movement between settings to help reduce the spread of infection, limit the use of public transport by members of staff, supporting safe visiting in care homes. There was also a 5% increase on contract rates and full cost recovery from March up until September. The 5% is still in place, and continue to monitor and review the financial sustainability with the care home sector. So we are, working with providers and those that are having any financial difficulties. We are in conversations with those providers. Next slide, please. Support for residents. So the care home providers have developed numerous ways of supporting residents' well-being throughout the pandemic. I mean, this list just, it just details a few. I mean, that they are doing an absolutely amazing job out there. And that's just a few. You can see for yourselves, obviously, the regular family calls via Skype or Zoom or a mobile, depends on the technology, on the individual, how they want to liaise with family, if they're able to liaise with family, etc. Some providers do the wake up and shake up to, keep moving. It not only helps the residents, it brightens the morale of the staff because they're all joining in and keeping moving. One great idea was the personalised hug cushions. And obviously that took a lot of to get off the ground because they wanted the families from photos, so there was all that involvement. And they got cushions printed for their resident of their family. So when their daughter or son or whoever is standing outside of the window and they can hug the cushion with the picture of the daughter, which was really great. I mean, they've been doing bake-offs. There was a lovely last waltz. One resident wanted to, put on a finest and wanted to last waltz. Was absolutely amazing. VA Day celebrations, believe it or not, you can see it there, but one of our homes actually celebrated Christmas in May with a lot of the community involvement. The community heard about it and, they were delivering lots of presents to the door. Absolutely amazing work. The hydration therapy, the Hawaiian Day, continuing all of the good work that the CCG did last year. So that work's continuing even through the pandemic. There's a pen pal initiative, which is great, and the care home managed to have an Elvis tribute act. It's one of their residents, it was one of their residents' last wishes. Sadly, that resident passed away this morning, but they managed to, you know, get that tribute last week, and the gentleman's died this morning. So, I mean, I could go on. They're doing absolutely amazing stuff. I can't, you know, that was just a few that kind of stuck with me. Next slide, please, Lindsay. And again, support for staff. While care home providers have had access to national support, they've also developed their own ways of supporting staff wellbeing throughout the pandemic. And again, I can't list everything, but this is just a sample. Regular staff welfare checks and support calls via Zoom, the increased frequency of one-to-ones, greater management presence, increased staff payments. Some staff are receiving an increase in their wages throughout the pandemic. Employee support helpline, staff incentives. You know, a lot of the communities are giving a lot of donations, local businesses. So, you know, they're holding raffles to try and, you know, just keep up the momentum and try and reduce staff burnout. So I also know not all the providers have told us what they are doing. So we'll continue to work with them to understand how they are helping their staff and make sure we continue to share this information across all providers. We're well aware that in the forums, we're obviously holding forums now every 2 weeks. So every 4 weeks we'll have a overarching forum for all 46 care home managers and the 7 specialist managers. And then 2 weeks later, we then hold the 7 PCN meetings. So we are in regular contact, but we are aware that not everybody is willing to speak up in the large forums. So they drop myself or my team emails, and we're in regular contact with the care homes daily anyway. Next slide, please. The visitors protocol. Obviously, we recognise how important receiving visitors is for supporting the health and well-being of residents. It also, believe it or not, it supports the staff as well, because they love to see families interacting with each other. So we hope that the updated national guidance on care home visiting, which, as you all know, was published on Thursday, will help care homes to support safe visits during this new period of restrictions. Now, prior to the release of the new national guidance on Thursday, discussions had already begun between the North East Directors of Public Health and the Directors of Social Services to develop some regional principles to support visiting, safe visiting in care homes. Now, these principles have now been adapted in light of the updated national guidance, and we will be sharing these principles. Sorry, I've just lost me. I've just had a pop up on my screen. Sorry about that. These principles have now been adapted in light of the updated national guidance, and we'll be sharing these principles with care homes imminently, hopefully this week, to further support them to put in place safe visiting arrangements. Whilst it's not possible to offer a full range of visiting options, we hope that the updated national guidance, alongside the local support and advice from our public health colleagues, will enable care homes to support some provision of visiting going forward. And I've included the link to that new guidance, which, as I've said, was published on Thursday. Can I have the next slide, please, Lindsay? So what we continue to do, so myself and my team, we contact the care homes daily across the city. So this enhanced daily communication supports the care homes, and hopefully we can respond to issues before they escalate. We do a weekly provider bulletin highlighting the latest guidance and support. That's to try and cut down on the email traffic. As you can imagine, they're bombarded, and you know, they may work with more numerous local authorities. So in Newcastle, we do a provider bulletin. So hopefully it's all in one place. Unless there's something urgent that needs to be communicated, you know, we'll try and contain it to the provider bulletin. Within that weekly provider bulletin, because we felt it was all doom and gloom, we now always ask providers for all of that good work that I've told you about, that we also publish some good news stories on a weekly event, just to pick up the morale, and it picks up our spirits as well. I've briefly touched on, we have the provider forums, bringing the providers together to share best practice, any issues affecting the sector. One good thing from that, I mean, it doesn't even have to be the same provider organisation, but managers are actually, when I've got a care home struggling, in a care home that's been there, done that, got the T-shirt, come through the other side, so they've learned all of the lessons, that, you know, they've addressed the issues. They're actually, Pauline, you can give them my contact details, and they're sharing. So a manager that's struggling is then, you know, getting that peer support from another manager in how they overcome those issues. So that's really good. And as I've mentioned, it's not just the same organisation, it's small provider, large providers. And that was the same with the PPE in the initial, you know, in the initial days when they were struggling for PPE, they were helping each other out. Again, they didn't necessarily have to be a Kari helping a Kari out, but, you know, they were all helping each other out, which was absolutely amazing. They were putting PPE in taxis and it was going until they could get their deliveries in. So there's some great work happening in the city. We've also, our public health, have our local single point of access known as the SPOC. So those reporting arrangements enable them to understand suspected as well as confirmed cases, in addition to information received through our daily calls and the national testing programme, in order to help mitigate outbreaks occurring. So there's a lot of great work that's happening, you know, throughout. Next slide, please, Lindsay. And the designated setting for COVID positive care home residents who are discharged from hospital. As some of you may be aware, the Adult Social Care Winter Plan and the links there, that should hopefully work for you, which was published in September, set out the government's plan for the next phase of COVID-19 response. The plan includes a commitment to deliver a designation scheme with the CQC, Care Quality Commission, of premises for people leaving hospital who have tested positive for COVID-19 and are transferring to a care home. So obviously we're working with our partners together to put in place this designated setting to support this objective. And we have gone through a procurement process and we have secured a provision in Newcastle. It just, the award letter hasn't gone out yet, but it is imminent. I think that's me done, Lindsay. Is that my final slide? Right. Is there, yes, Anne? Anne, do you have a question yet?
Yes, I do. Thanks very much for that. And it's good to hear that all of the positive things that are taking place at the moment. Can I just ask, right at the beginning of your talk, you indicated, you didn't actually say this, but you indicated that not all of the care homes have taken up the infection control training. Have you followed this up? Do you know why? I mean, have they got training elsewhere, or?
I think, and a lot of them, obviously, I also mentioned we've got the wraparound support for the care home. So we've got the care home support team. So that's the nurses that obviously go into the care homes. If not on a day, they're the ones doing the flu injections. So there's been a lot of training from the infection control lead nurse, from the care home support team, whether that be, you know, the COVID, the PPE, the donning, the doffing, I don't have a full list. I know some of the majority of providers have taken up the free training. There's also been online training. You know, the nurses have been into homes. I don't have the full exhaustive list of who's took up what, but I'm sure the care home support team have that list, or the lead infection control nurse. But all of that, you know, good practice and training is happening. If there's any issues that are brought to our attention, all that I need to do, which is brilliant, you know, the collaborative working, I can either drop an email or I can pick up the telephone and speak to the care home support team or to the lead infection control nurse if anybody is struggling in any of the care homes. This has also happened in the community, by the way. In our lead infection control nurse will make contact with the particular manager and either do a visit if a visit is required, or find out more about the situation.
Okay, thanks. So it will be monitored.
But the training is there, but I'm sure, you know, it wouldn't be too difficult to see who hasn't. But I would say, I think hand on heart, I'd say about 96% have probably will have done the training. Does that answer, Anne?
Yeah. I mean, it's from my point of view, as long as it's being monitored and you or somebody is picking up, you know, where there are gaps to ensure that the training is complete.
Yeah. Right. Obviously, I've mentioned we do our daily calls. I also have regular. They used to be weekly. Now they're fortnightly. So we have the CQC information sharing meetings as well, which is obviously safeguarding are in there. Our health colleagues who's on this call, the safeguarding from the Newcastle upon Tyne hospitals. So any issues that are highlighted, obviously we're public health colleagues, we'll work with the public health team, with Public Health England. So there's loads of great work happening. We're maybe not just great at selling it, but there's loads of great work happening. So if we thought that there was any training that needed to be picked up on, then, you know, and I contact those key people, and I have 100% confidence that those people then either they'll do a telephone call and then they will make a visit to that at a time that's suitable for the manager.
Right, thank you. Can I ask something else very quickly as well?
Yes, Anne, yeah.
I noticed that you've picked up on the DHSC guidance that was issued last week, and you've updated your all the measures accordingly. And it's great to see that everything that's being put in place to protect and to help the residents of the care homes, you know. But please remember that many of these people are our relatives, our family, and a lot of us are older people as well. So we, in these circumstances, we can't visit. So we actually miss the hugs and the holding somebody's hand and the conversation with them as well. So that's fine.
I mean, the care homes are working and will, you know, visiting will resume. It has to be risk assessed and it will have to be managed. Obviously, all, you know, right, you need to see your loved one, but again, that has to be managed. We do have a 99 bedded care home that is full. So obviously all 99 relatives, it would be impossible that, you know, so it does have to be, you know, bear with us. I know a lot of families, yous are doing amazing and yous are really supportive of the managers, and they're doing their best. You know, that they really are doing their best, and they will try and facilitate. They'll do their best to facilitate, but it must be safe visiting. And if there is any outbreaks, then obviously public health are involved. And if there is outbreaks, then, you know, the visiting will stop on such occasions. But we are doing our best to work with them, and they miss the families as well.
Okay, thank you for that.
Thank you. Cynthia, did you have a question?
Really, just a point to make, Pauline, just to echo the thoughts of the comments on the collaborative care homes. how successful and informative that has been for Healthwatch attending it, but also just to thank you for sharing the information that we asked in terms of asking people's views and experiences in terms of during the COVID period. So thank you for working with us on that, Pauline. That was greatly appreciated.
Oh, thank you for that. Is there any more questions before we move on?
Pauline, just one thing from me just before we move. I mean, one thing that's from a CCG perspective that's been really encouraging, if it is such an encouraging thing that to come out of COVID, is that the work as a system between sort of the local authority, the CCG, the Acute Trust, Public Health England, has been very, very, very good. You consider where we were at the middle of March to where we are now, and I think the system working has been superb. There's some things that really, really have improved over the period from that perspective. Okay, so if everybody's happy, we'll move on. Cynthia, I think you're up next.
Yes, I think I am.
Thank you.
Yes, I no slides because I did read about people being a little bit slide fatigued, so I'm just going to talk as I usually do, really. Just to really inform you, first of all, we do have a new Chief Executive Officer being appointed. Siobhan O'Neill has started for Healthwatch Newcastle and Healthwatch Gateshead. So she's already started, but I'm still sort of involved during the handover process. So I'm sure Siobhan will be delighted to attend future meetings. In terms of our feedback that we've had, we've actually produced a report called 8 Ways to Make a Difference report, and that was focusing on children and young people's mental health. So we've recently published this, so it's out on our website. We've done that and promoted it through increasing our social media platforms. So right across all the social media platforms, we've been talking about the feedback that we've had. We've done some work also that was interesting with young people, and I know it was mentioned in the earlier slides from Chris. So some of the feedback we've had is very interesting. I'd like to share it as part of what Chris was feeding back. We've had things like, there's a long wait. This is from young people. A long wait in the A&E causes some self-treatment, and some were hesitant to actually use GP services because of the wait. We know our young people, I don't blame them, aren't particularly patient with things. There was also very much raised about the lack of awareness of autism support groups. Very little communication for speech therapy for a year. The early morning booking system was seen as a barrier for some young people. The same day consultant appointments making it difficult if they needed to take some time out to do that. But this is going to be in our report, and we'll gladly share that, across this group. I didn't want to say this, but I am going to say it because some of it was staff attitude. And it was staff attitude at reception staff again of GPs, but I think it's a really, really difficult time. But we have to respect what young people are telling us, so that's why I've said it. So they felt that some reception staff were a little bit patronising and disrespectful, while some agreed most parents and carers described them as friendly and helpful. So it's different coming from a young person's perspective, really, isn't it? And I would love to take the time for us to do some more in-depth work with them on what we could actually do to improve that. We've had positive feedback from young people about pharmacy staff, including them, and being friendly and thorough and professional. Dentists were also described as being kind and very, and somebody said, and just lovely with young people. So there's some mostly positive, during the engagement that we have undertaken. But there will be a full report, and if people want me to, I'm happy to send it for everyone. Nationally, we've been looking at accessing what people feel about accessing dentists, because this came up nationally that people were really struggling with getting dental appointments. However, in this area, and this is Newcastle and Gateshead, we've only had a couple. We've only had a couple of people saying that they really struggled to access their dentists. And on the whole, I have to say the feedback we've had from both young people and other people and the other groups has been very positive. There's been some very, very positive comments on how helpful everyone has been, and how good it is to see us all working together. The one thing that did come out from hospitals, and this was nationally, was for staff to actually just be able to provide clearer information and more reassurance about what will happen and how safety is being maintained. Obviously, we all know that anxiety levels are high with people, and I feel this is what I personally feel that this is why this has come out, because I know I'm very anxious with appointments at the moment. So I think it's just worth noting that perhaps, you know, the way that we're communicating, we could always look at ways of improving that. Definitely the other one was clear communication. Again, has been challenging for patients and public. So it's nothing unusual to what we haven't had pre-COVID, really, about communication. But personally, I feel attending the meetings that I have, we've actually worked extremely well together, and always looking at how we communicate that clear information to the patients and the public in our communities. As I mentioned earlier, we are going to be doing some work with Newcastle primary care networks outer west. And again, that's engaging with patients on gaining what's important to them, what their experience has been in terms of digital services, and really emphasising looking at ways at people that are digitally disadvantaged, and that's not very easy to say. But also to be very, very mindful that we're not all digitally confident, you know, and I just feel we really do need to recognise that. So that's a brief update from Healthwatch, and we just continue constantly signposting, constantly pushing that information, the message out there for people's safety, and that's what we're continuing doing across Newcastle and across Gateshead. If anyone has any questions, I'm happy to take them.
Okay, has anybody got any questions for Cynthia at all?
Wow, that's good.
Wow.
There's just one question in the chat there, Cynthia. Stuart's asking if the report for the work for young people is on the website.
Not yet. As we speak, we are just finally agreeing it to go on the website, Stuart. As soon as we get it, I mean, I can share it with this group, Lindsay, as soon as we've got it absolutely clear. And the same with the digital consultation report. Can I just send that to you, Lindsay? I think that might be.
Yeah, that'd be brilliant. Then I can email it out. Yeah.
Yeah.
Mm-hmm.
So that was my only question, and the only reason why I'd asked is because I'm 24 now, and I think next year I'm going to 25 next year, so I'm going to be out of that bracket for young people. But whilst I'm here, I would like to do as much work as I can with young people's voices heard in designing of services, and I've managed to link up with a few national advisory groups. So that's why I was asking about this, because if I can pitch that to them, and then it might be like potential for wider work around young people's involvement in service design and service delivery as well.
Stuart, you're certainly on my list of priorities, and I have your email anyway. I'll make sure.
Yeah.
Cynthia, just one from me, then you're not going to get off that lightly. You mentioned that there were sort of some of the young people identified issues around practice staff, particularly reception staff.
Yeah.
Is there any sort of particular areas or any particular concerns that you've got around that? And is there something that we can address from a CCG perspective? I mean, clearly what we can do, we can put stuff in the staff bulletins, or we can actually target particular groups of practices. So I'm just wondering if you had any thoughts on that.
Well, we're looking at it, and it's such a difficult time, to be honest, Neil, when we were reading through some of the comments, and we know, you know, we've clapped for the NHS, and NHS are under so much pressure. And I personally am a great supporter of the services, and I struggled in informing that. You know, I really did struggle with that. So I think probably in our training team meeting next week, this just literally come out. So I'm going to have a discussion with them first and just find out where it's come from, you know, where the information has come from. Obviously, it isn't sufficient for us to escalate, Neil. If we get more than 2 or 3, of course, we have an escalation policy, and we would write to a practice and just say, you know, give them the heads up that people have said this. But what I can do is certainly after the meeting, after we've delved into it and look at what we could possibly do for the future, I'll certainly get back to you on that, because it is important. And sometimes people just say these things and we need to follow them up to make any improvements. Yeah, so I promise I will do that.
Oh, that's brilliant. Thanks very much, Cynthia. Has anyone else got any other questions before we move on? I think you are going to get off quite lightly, you know. Okay, well, look, it's 3 minutes to 3. I think we've got a break scheduled from 3 o'clock until 1:15. So I think that's really, really good timing. I think a lot of credit's got to go to Lindsay and Chris for keeping this sort of very, very sort of well controlled and well timed. So thanks to all the speakers so far. If you'd all like to come back, sort of take a break, have a cup of tea, whatever you like, and we will see you at 3:15.
Thank you.
Okay, welcome back, everybody. It's 3:15. Chris is not back yet, so I'll just continue the chair until he gets here. The next speakers we have are Hilary Bellwood and our medical director, Dominic Sloey. And they'll talk to us about the planning and development for the next few months. So can I pass over to you then, Hilary and Dominic?
Yes, certainly.
Thanks.
Yeah, that's not a problem. So, Lindsay, will you do the slides?
Yes, no problem.
Thank you. So, hi everybody. My name is Hilary Bellwood. I'm the head of planning and development at Newcastle Gateshead CCG, and I would think that some of you will have seen me before. You know that where we are at the minute is that this isn't a normal planning as we would normally engage with you about our annual planning cycle. You know that usually round about September, October, we start to get indication from the government about what our money allocation is going to be, and we come along to your various meetings and start to say, well, you know, what's going well, what's not going so well, what kind of things should we be looking at. But as I'm sure everybody's very cognizant, we are in such a difficult and different time this year, and hence, you know, I've come along just to give you a bit of an update about phase 3 planning. Dominic and I will talk through things. I'm just going to give you some of what I always call the technical aspect, which is the stuff that comes down the line from the government that says, you need to write us a plan, you need to do this, etc., etc. But actually, behind all of that is the patients and public, and what we want to try and do today is give you a little bit of a flavour about the other things that are still happening, because it's extremely important that we do that. So going back to July, going back to phase 1, what we called phase 1, which was when we had the COVID level 4 incident response. And sadly, here we are again now, we're back into a level 4 incident response. But I think the biggest difference is that we've learned so much from March and what happened then. I mean, even just, I was listening earlier to the talk that was happening about the care homes and all of the things that we've tried to put in place. These are the things that we've learned from earlier on in the year. But you know, everybody's in a very, very difficult situation. It's not easy for anybody. But what then happened was that we had what was called a phase 2, which was to talk about what was going to happen with critical services, how they would be switched on. We then had at the end of July, and what we then had was a letter from Simon Stevens and Amanda Pritchard, and that was very much around how we were then going to set out priorities for the autumn and the rest of the financial year. I still think that what we might find is that there will be some further guidance later on in December, but we're just waiting to see. So next slide, please, Lindsay. So as you can see from the slide, what we then got into was some very detailed information that said phase 3 planning, what we were asked to do was accelerate the return of the non-COVID health services to try and make full use of the capacity available between then and winter. And here we are in winter. What I would say was there were some very, very ambitious targets set there. What the government were looking for, you know, they were responding to what had happened in March and the kind of things that people fed back about, which we knew was a big concern, such as things like waiting lists, long waiting lists, people waiting for cancer, people having chemotherapy. And I think that was the concept that they wanted. They wanted to see more or less a return to what was happening a year ago in September. So at least 80% of last year's activity for both elective care, so that's planned surgery and things, and day case procedures such as endoscopy. They were looking at diagnostics such as MRIs and CT procedures. But I think everybody recognised that everybody was trying very, very hard to do that. You know, when it talked about full operation of cancer services, improved mental health services, I think at the back of our minds was that everybody was trying to do that. It was very ambitious, But I think that it's good to think about why some of those things didn't happen. Some of it was because of things like PPE. Things did still happen, so via cancer hubs and things. And we know that the government purchased a huge amount of extra capacity into the private sector. So that's why there was capacity for things to happen at places like the Spire and at Cobalt Business Park. Because for places like Gateshead, they are a single site hospital, so it isn't as easy, if you like, for them to try and rearrange things in order to get things back together. And I think you know, we talked to the trust throughout all of this. We wrote a joint plan on how this was all going to happen. And I think it's fair to say that for some of them, even things like, you know, when they, at their most critical point, when they were using their theatres for things like intensive care units, when there was people on ventilators and, you know, everything was running at full capacity. So putting all that back into place wasn't easy. But similarly, we could understand where the government was coming from in terms of wanting to restart services, but all of that had to be very much balanced. And I think, Lindsay, could you put the next slide on? I think where we were all coming from at the same time was that we were preparing for winter, but alongside a possible COVID resurgence. And as I say, here we are again in that situation. There was a big emphasis also in these the phase 3 plans around inequalities and just recognising that we needed to look at protecting the most vulnerable, and that was patients and staff. I think that we mustn't take away from the fact that some staff had to be moved away from the first line, from the front line, you know, where they were BAME staff, where they had underlying health conditions. So all of these very much played on some of the things that happened in the first wave of COVID and are now happening again in the second wave of COVID. But similarly, we absolutely have looked at protecting the most vulnerable, getting things restored. And I think it's interesting about when we talk about digital enabled pathways are inclusive, because I was listening in earlier to some of the feedback, which has been, you know, excellent. And I think it's what everybody recognised, that we mustn't disadvantage people in terms of how they access services. Yet on one hand, you know, the use of technology is good, but it's not for everybody. And there are times when it's not appropriate to have a digital consultation. So I think you know, all of this information has been really useful in terms of when we wrote our plan, and not taking away the fact that, you know, in terms of mental health and the increase that we've seen and all of the things that have been happening, you know, trying to reinforce the messages about services such as COOT, talking to you know, the trust, the CNTW trust, about what they can do in terms of access. I think all of this has been going on in the background, and we've tried to build that into how we move things forward. And similarly, how we collaborate on planning and engaging with communities. Could you put the next slide up, please, Lindsay? So I think this is why I absolutely loved the document about the 5 principles for the next phase of COVID, from the national voices, about nothing about us without us. I think we're very cognizant of the fact about actively engaging with those most impacted by the change, and it's good to hear that the engagement that's been happening, and what we need to do as we move forward. Absolutely. And I think I was, you know, I reflect sometimes on that statement that came through about making sure it's going to be more compassionate and equal, with people's rights at the centre. We've not got to lose sight of the many people who died or who lost loved ones, or whose lives have been made immeasurably more difficult, because they deserve nothing less. And I think listening to all the discussions about the care homes and what's happening, it's brilliant to see what's been put in place since March, but equally recognising that, you know, it's still not perfect by a long way, and there are other things that we know that need to happen, and, you know, we continue to talk to everybody about how that can be done. So Lindsay, could you put the next slide up for me, please? So from the planning guide, what happened was that as a CCG, we are part of what's called the North of Tyne and Gateshead Integrated Care Partnership, and we had to write a narrative basically, and that narrative was co-produced with all of our providers, and we talked to many well, the primary care as well. But ultimately, our priority at that point was getting services started again, trying to restore performance levels. But there were a number of caveats that I've touched on that I think it was important that we put into that narrative, because if we weren't able to overcome things like COVID-related capacity constraints, such as physical distancing, infection prevention and control, thinking about even the impact of this on things like patient transport, and again, all of our plans that were submitted were based around the R rate being less than 1 or less, which, as we know, didn't happen. And I think it was fair to say as well that even down to things like where we put on extra services for endoscopies and things, just recognising that it's all right saying, well, you know, we've put all this on at somewhere like Cobalt Business Park, but even then, that's not always easy for people to get to. So I think we've just got to keep all of this in our minds as we continue to move forward, and make sure that, you know, we talk to everybody as much as possible and as frequently as possible as we need to. So could you put the next one up, Lindsay? So Dominic's going to talk through, because we just wanted to give you a little flavour about where things were at the minute, in terms of both of the hospitals and things, and also what's happening within primary care. But happy that, you know, talk at the end if people have any questions.
Yeah, thanks, Hilary, and please do give us your questions, because this is an engagement event, and in terms of those principles that the National Voices team outlined, this is one of the ways that we're sort of trying to hear from you about what's going on and what's working, what isn't working so well, so that we can respond to that. So the first slide is quite busy, but this is data as of last Wednesday from Newcastle hospitals, and we've got a similar one to follow for Gateshead hospitals. Just gives you some of the facts and figures about the number of people with COVID in hospital at the minute, the amount of spare capacity there is in terms of beds, and just a few things to sort of bring your attention to, I suppose. One is the sort of graph right in the middle of the slide, which shows the number of confirmed COVID cases in hospital across the whole period. So you can see in phase 1, the peak of the first wave of the pandemic around sort of mid-April into May, there was a high peak there. But the most important thing I think to recognise from this graph is that if you look at where we are now on the 1st of November, we're not 100 miles away from where we were back then in terms of the number of people in hospital with COVID. Now that the curve has gone up more slowly, but we're sort of nearly at that sort of same level. Interestingly, the one next to that shows that even though we've got lots of people in hospital, we've not got quite as many going into ITU this time, or there's a lower percentage in the intensive care units. And I think that's reflecting some of the learning that we've had from the first wave. We're knowing that if we give people steroids at an early stage, that they'll be less likely to need ventilation. If we care for them in a prone position where they're lying on their fronts, they do better. And CPAP, which is like an assisted pressured oxygen mask as opposed to a ventilator, that also helps. So they're sort of interesting. And you know, up in the top left corner, it tells us that Newcastle Hospitals has approximately 1,400 beds, and as of last Wednesday, 22% were unoccupied. What the slide doesn't sort of tell us in great detail is where the staffing is, and I think that's a really important point here, and it's perhaps more important in Gateshead at the minute than it is in Newcastle. But there's a box up here that says staff all absences 1,000. So that's quite a lot of staff absences, and that's another factor that is perhaps even more prevalent in this phase of the pandemic compared to the first phase. And I'll say why that is in a moment. So if we could just go to the next slide for Gateshead to do some comparisons with Gateshead. So, so the biggest difference, I suppose, to bring your attention to is that top left-hand box. The number of open beds in Gateshead is 468. So that's much lower than in Newcastle hospitals. And the number of unoccupied beds, the green bar on the histogram, that's just 12%. So in terms of the patients that are in with COVID and the amount of spare capacity that the hospital have got, Gateshead have got far fewer. And even though they've got a lower number of reported staff absences, I think as a percentage of their whole staff, it's arguably higher. And this is a big thing that's different in this phase of COVID, because we're testing far more people this time. And because we're testing people that are well this time, and then there's a self-isolation consequence for contact, that's meaning that not just the hospital trust, but general practices as well, are finding that they're having significant numbers of staff that are having to be absent because they've been told by contact tracing that they have to self-isolate, or in fact that they've tested positive themselves, but they're not unwell enough for hospital. So that's a big factor that's different, because in the first phase, you might remember, we were only really testing those people who were going into hospital or were NHS staff themselves. So if we could just go on to the next slide. So this is a slide to sort of just capture a few of the headlines in terms of how we're doing. So the first thing to say is that the NHS is open, but I think one of the important things to recognise is that here in the North East, we decided from an early stage we weren't going to suspend any activity fully. We were going to keep doing what we could, but prioritise urgent and cancer work. So no urgent medical work, no cancer work actually stopped either in primary care or secondary care. But as Hillary's already indicated, we've been trying our best to get back to as near normal activities as possible during this phase, including the non-urgent work. And that, again, is causing an extra pressure, I guess, this time that we didn't have the first time. But the hospitals and practices have all been brilliant, really, at thinking about how safely patients can attend and how the PPE can be used to prevent transfer of infection. So if your hospital is inviting you for an appointment, or if your GP is saying, well, you know, a telephone call isn't going to do it on this occasion, we really do need to see you face to face, then I just want you to feel reassured that the practice will have already thought about how to do that in the most safe way, and you will not be sitting in a crowded waiting room. It will have been all thought out very carefully. We've mentioned that emergency and routine activities are continuing in hospitals, and currently I think we're just keeping our heads above the water. So you may have heard on the news that Manchester has had to cancel all elective activity, and by elective activity we mean those planned interventions like knee replacements and cataract operations or outpatient appointments. So far we haven't had to do that, but you know, I don't want to be dishonest. You saw those last two graphs. We're possibly not far away from having to think about whether we might need to cancel a few things, but of course we will always prioritise cancer care and we'll always prioritise urgent care. And the good thing is that it looks like our cancer referrals are now similar to where they were before the COVID pandemic. So we are really doing quite well at seeing these patients and getting them the treatments that they expect. Though within that 2-week window that sometimes people expect for a new referral, it's fair to say we're not always doing it within 2 weeks. It's sometimes taking 3 or 4 weeks. Routine surgery, again, doing very well, and you'll have heard of, and you may have been invited yourselves for routine procedures as expected. There are some exceptions to that. So there's our particular backlogs for some specialties. So skin, dermatology lesions, there's quite a lot of backlog for those, and cataract surgery, but I'll say a little bit about that as we move on. But people might also be experiencing that hospitals are doing their appointments in a slightly different way. So a little bit like general practice, people are being offered telephone appointments or video appointments. And we've just been given some funding today. We've got news that we've got some funding to think about how we make those digital platforms inclusive, how we make sure those people that might have sensory impairments, visual problems, hearing problems, language problems, how they're not disadvantaged by the digital platform. So that's something that we're actively investing and researching in as of today. As is not surprising, the waiting times are going to be going up for things, and we are going to just ask you to bear with us for some of that, you know, the pressures that we've just described. And so inevitably, I think there is going to be a longer wait for some things. But the important thing is that hospitals are contacting everybody on the waiting list just to see whether the circumstances have changed. But also, more importantly, I think in terms of the health inequality agenda, we are asking hospitals to look at the additional needs of people who are waiting. So if you're a carer, if you've got additional disabilities, the hospital are taking that into account in terms of their waiting list. And that's a really important thing that I just wanted people to hear about us doing. So people that don't want to attend because they're feeling anxious and despite the reassurances are still saying they're not ready because they're shielded or they have previously been on the shielded list. We're respecting their wishes, but they will remain on the list. But the shielding advice was just published last week, and it is, you know, it's not saying that people with additional vulnerabilities have to stay inside. It's saying that they just have to take those precautions for social distancing. So certainly the government advice is that if you are vulnerable, it is safe to seek hospital care, but clearly we respect people's decisions. So if we could just move on to the, I think it's the last slide for me, or last but one. So Hilary also mentioned that hospitals have to follow the guidance in terms of keeping social distancing between patients in outpatients and inpatient settings as much as is possible. And there are the staffing pressures in terms of staff being absent. So this is what's sort of slowing things down inevitably. And there are waits for some of the diagnostic tests that are quite important for people in terms of having a diagnosis made. So things like endoscopies and various hearing tests, these have all been slowed down a little bit. But there are new pathways as well. So for example, people with bowel symptoms that we are concerned might represent a cancer. There's a new test that we're asking patients to do called a FIT test. And this takes a sample of their stool and it can very accurately predict the likelihood of cancer and filter out those patients that really do need to go on to that second stage of an endoscopy versus those that it's very safe to wait for. So that will feel different to the way we were doing things before. But what it also means is that we're going to be able to get those people that need those endoscopies through the system sooner rather than having a massive wait. So we think that's a very positive thing. And similarly with people that are concerned about potential skin cancers, we're starting to bring in, probably just before Christmas, a new way of accurately photographing lesions and sending those photographs to the specialists at the hospital to make a decision on whether or not your lesion needs to be seen in the hospital face to face or biopsied directly straight to a biopsy clinic. And again, this is a new way that we can filter out all those lesions that, you know, an expert can look at very quickly and say, no, we don't need to worry about that. So these are two examples of new ways that we're trying to achieve faster diagnosis.
Dominic, would it be fair to say as well that I'm just looking at, you know, when we talk about wards being reconfigured and workforce pressures and capacity reduced, you know, we know that in most of the hospitals, instead of having 6 beds in a room, that's had to be reduced to things like 4 because of the the social distancing and things like endoscopies, because of the way that it's an aerosol generating procedure, that the time between endoscopies has had to be reduced. And again, because the staff have to wear full PPE, the donning and the doffing takes much longer. So perhaps in the past, you may have been able to do, I don't know, just example, say 20 endoscopies. Now that's almost halved and things like that. So I think it's just it's good to just have that discussion, isn't it, and make people aware of that these are the things that we face in.
Yeah, so we definitely can't do nearly as many as we were used to doing because of that time that you need in between. But that's why it becomes even more important to make sure that the ones that you're doing are the ones that you really need to be doing. So it's great that we've got these extra technical sort of tests to allow us to sort of tell people they're safe without having to go through an endoscopy. So the other thing to sort of say is that cataract surgery was already had established quite a long waiting list, unfortunately, prior to the COVID pandemic, but clearly that has worsened significantly. So we've been actively working, not just our CCG, but our neighbours in North Tyneside and Northumberland, who all use the Newcastle Eye Department for cataract surgery. Looking at a new facility to do very fast-tracked cataract surgery on the old Newcastle General site. And we've put in a considerable amount of additional funding. And from December, we're hoping that there'll be massively increased capacity to then work through that very long backlog of cataract operations. So hopefully that will be felt as an improvement quite soon. We're also using beds in private hospitals, so that's an active conversation that's going on. If there's capacity there for planned operations, we're using it. And we're also looking at those people who've had to wait a very long time. Some of the spinal surgery cases are having to wait a very long time. We're actively reviewing those to make sure that people are not coming to any harm. So whilst we're doing very well, I think we've got some additional pressures this time round that we didn't have last time round. And I think inevitably, in a resource limited system, there is going to be some impact. But the message is that please contact your GPs. Please bear with us if you're having to wait slightly longer than you might have expected. We are still having to prioritise the more urgent cases. And so for very routine or mundane things, it might be that you find that, you're not going to get something done quickly. But I just want to reassure people that if it's urgent or we suspect it's cancer related, or even it's to do with the ongoing monitoring of your diabetes or your chest problems, that we're there to do that, and we are doing that. So please, be in contact with your surgery in the first instance.
Chris, I didn't know whether was there an update about the Nightingale? I wasn't sure whether people might be interested just to understand what's happening there.
Sorry, I was on mute.
Sorry.
It's unlikely we'll be using the Nightingale Hospital in the short term. I think that's on hold at the moment, waiting to see what we need to do and watch a very watchful brief on how the hospitals are coping, really.
Yeah. But again, that would impact, wouldn't it, in terms of like workforce capacity as well. So, because I think, we know that you see things in the media, don't you?
Yeah.
Yeah. Shall we? People want to ask any questions? I see there's a couple of hands up.
Steve, I think you were first.
It was concerning those graphs that we were shown. Can we go back to them? Dominic, is it possible to go back to them?
Yes, it would be. Do you want to see the Newcastle or the Gateshead, or does it not matter?
Well, the Newcastle. I'm from Newcastle, so might as well have a look at them.
I'll pull them back up if you want to move on to the next question, and then I'll pull them back up because it might take a couple of moments.
I can't see any other hands at the moment. Were there any other questions whilst we're coming to that slide?
There was. I think, Kate, you had your hand up as well.
Yes, I did. Thank you. Actually, it does relate to the Nightingales. I was wondering, exactly where does the capacity come from to staff either Sunderland or Harrogate. I'm assuming we're the Sunderland one, but I presume if we had to, we could use the Harrogate one. So where does that capacity to staff those come from? And does it mean that if you had to make a choice, would you have to cut some of those interventions that you've just been going through, Dominic, as sort of standard work that you would be doing normally? Does it, in order to staff those nightingales and keep people there and therefore away from our general hospital patients, you know, how would that be done?
Yeah, well, I think, Kate, you've hit the nail on the head, really, and that's the $64 million question, because we only have so many trained nurses, doctors and allied health professionals to staff what we've got already. And as we've said, what we've got already is under significant pressure because of staff absences, either due to staff getting COVID or having to self-isolate. So I don't think anybody's got the answer as to how we would staff those nightingales should we need to step them up. So you know, we have no more information on that than you do, other than that's going to be the rate limiting factor. And then you know, even if they were operational, we would be facing the same pressures in terms of routine and planned care that we're facing now, possibly even more so. So we're hoping that isn't going to be needed, I guess, in the first instance. And secondly, our public health colleagues are expressing very sort of cautious optimism that because the rates of the graphs aren't going up very quickly, and because in our local authorities, the 7 local authorities in the north of our patch, we actually started a local lockdown even sooner than the tier 1, 2 and 3 and the sort of full lockdown that started on Thursday. We started that a lot earlier. So there is some indication that in a slightly different way to other areas of the country, we might have started to plateau in terms of our numbers, but I have to underline that that's still quite cautious optimism. There's no certainty that we're turning a corner yet, and clearly our hospitals are extremely busy and perhaps even more precarious than they felt during the first wave at this point.
Thank you.
Okay, can we go back to Steve then? I think
it's just a question about that graph on the the third row on the left there. Inpatients diagnosed in the past 24 hours in a hospital setting. Does that mean that they came into hospital with something else and then caught the disease in the hospital, or does it mean that they came in as a suspected COVID patient and the confirmatory diagnosis was made when they got into hospital?
Yeah, so I think it actually means both, but I think the majority of the numbers underneath that part of the graph will be people that have come in because they had COVID and their condition has deteriorated and they've needed hospitalisation. So that is the majority, but we are seeing small numbers of people acquiring COVID whilst they're in hospital for something else. So they would be in that number too.
And what are you doing about that?
Well, I mean, Chris might be best to answer that, but we're doing everything we can, including sort of trying to isolate wards and close wards down. But Chris, you've probably got better information on infection prevention and control.
Yeah, actually, I can answer that question to a degree. What we are doing is working very closely across the northeast and North Cumbria to learn together how we can eradicate this hospital-acquired COVID. It is an only low incidence of it at the moment, to give you some reassurance. And we're increasing our education to the staff. We've done things like taking, as Hilary mentioned, taking beds out of cubicles to reduce the number of beds there to enable us to do social distancing in the cubicles. And we've taken every precaution we can now within the hospitals to ensure that this is safe and less likely to be transmitted during a hospital stay. Yeah. I think we've learned a lot over the last few weeks about this.
Could I ask another question, please? This news today that the Pfizer vaccine looks as though it might possibly be available before the new year. Will that make a big dent in that 1,000 staff absence figure?
It may do. Yeah, I mean, I guess of those staff that are absent, we don't know if they're absent because they've tested positive or because they are a contact of somebody else who's tested positive. And what we don't know is what we're going to do differently in the testing and tracing system, which has perhaps not performed as everybody had hoped entirely. Would probably be the only diplomatic thing to say. So we don't know how we're going to change that.
It's world beating. Come on.
Yeah. So we don't know how we're going to change that, because clearly if we get significant numbers of the population vaccinated, then an exposure isn't quite the same significance if you're in contact with somebody. So there is a lot of hope that the vaccine will be effective. Certainly today's news item suggests that, and there is already a plan of how we will immunise people at scale in this country, starting off with the most vulnerable people.
Thank you.
Okay, thanks, Steve. Judy, I think you're next.
I'm unmuting now.
Yeah, that's fine. We're here.
I just wanted to say something about the Nightingale. It's in the public domain, this information. But as members of the, as governors of the hospital trust, we have been told that the Nightingale staffing plan is in place should it be needed, and we certainly hope it won't, because there is only a certain finite number of staff. But it is not just coming from Gateshead and Newcastle. It will be taken from Cumbria, Teesside, Sunderland, from the entire region. And the people who have been selected for this know who they are. We just hope they will not have to be used, because they can't be in two places at one time.
Judy, can I just confirm there is a plan, a staffing plan for the Nightingale, and it's our intention, hopefully, not to have to use that.
Yes,
as Dominic said, it's much better to consolidate on their existing hospital sites.
Absolutely, that's the message. But just to take it about one step further, it is not simply the north and south banks of the Tyne that are involved in it. It's a much wider area and would have a much wider staffing base.
Yeah, absolutely true. And it's not just doctors and nurses we need to recruit to open that hospital. It's domestic staff, therapy staff. There's a wide range of people we need to recruit. There is a plan out there. Martin Wilson from Newcastle has been leading on that.
Yes.
We're just hoping, fingers crossed, we don't have to implement that.
I agree with that. Thank you, Chris.
I think, as always, we're always very well prepared in the North East, aren't we? Because I think we've got a long history of collaborating together and taking leadership. So I always feel really comfortable when these things happen, because I think we've got people with so much experience, like Chris, like Dominic, like Martin. So it's really good. But I think it was just interesting as well, Judy, when you say about open up to other patients, because similarly what we were asked to do was, in terms of, we said that there's extra capacity in the private sector, so at places like Spire, at Cobalt and things, for patients to go and have other procedures. We also, that also includes patients from North Cumbria. So it was ironic, really, that we know that patients, often don't travel even to Cobalt Business Park from Gateshead and Newcastle, and yet we were asked to make sure that there was a certain number of beds available to patients both at James Cook area and our area from Cumbria. So, I think it's that bit about everybody's pulling together and trying to make sure that in terms of access, all of that's there. And I thought it's just interesting to share, one little anecdote finally about, we talked about people having access to consultations, remote consultations, etc. But we also had fed back through to us things like where people who don't have broadband, who can't afford a broadband, who even would go and sit in bus stops as buses went past to try and tap into Wi-Fi. So I think absolutely we've got to make sure that we are cognizant of everybody's circumstances and how that needs to work. So as I say, it was just a one little anecdote to share with you.
Thanks very much, Hilary. Has anyone got any other questions for Dominic and for Hilary at all? I think that's just about. Sorry, did you want to make a point, Dominic?
I was just going to say I'm really keen to hear people's experiences of how things have worked and to check that they are as we're describing them. You know, if you don't feel happy raising your hand in the meeting, please contact us outside the meeting if there are, you know, experiences that you want to tell us about. We'll use all the information we gather to sort of, you know, try and make sure we are sort of putting in place responsive services. I still consult one afternoon a week, and I've been doing a new style of clinic ever since the first outbreak. And I have to say, you know, I've been on a steep learning curve myself, but most of my patients from all age groups using phone, using video, and coming in when necessary. And I am bringing patients in for blood tests or to examine their tummies or look at their eyes or skin. You know, when it's necessary, I'm doing it. But I have to say, the feedback I'm getting from my patients is that they quite like the new way of working, that it's bringing some positives as well as an adaptation to doing things in a slightly different way. And we're getting stuff done quickly. We're getting people's sick notes out to them. We're getting people's prescriptions sorted out really quickly. And I think we've adapted remarkably quickly to this new way of having to do things.
That's excellent. Thanks very much, Dominic. Okay, has anyone got any other questions for either Dominic or Hilary? If not, has anyone got any other questions sort of from the presentations so far? Kate, I think is your hand up?
It is actually. I wanted to just follow up on what Dominic said. I was just thinking about, I mean, personally, I've dealt with a whole array of new people at our GP surgery during this period. So people who seem to be temporarily working at the surgery. And I've definitely a couple of times spoken to nurse practitioners. And the truth is everyone's been really kind, listened well, etc., etc. But I've been sent 2 lots of prescriptions that when I've read the side effects, I've chosen not to take those medications. And then I'm also left with the question, do I go back and try and speak to the GP rather than the other people to make sure I understand? Because I've read the side effects and thought, actually, you know, I don't feel this is right for me. I'm not prepared to take that risk. So you end up sort of on maybe a series of phone calls in that situation, and that bothers me a little bit. It's also that sort of, they took my bloods in the summer, and then I had to phone them to say, well, what came of that? Because it seemed to have got lost because there were different staff in the practice.
Yeah, so a couple of things to say in response to that, Kate. So thanks. Is that, you know, as always, continuity of clinician is quite valuable for many of us in many situations, because one person knowing the story is perhaps able to respond more safely and more appropriately than somebody coming in anew. So again, we try when we can to sort of keep people talking to the same clinician at the surgery. So my counsel would be, yes, do query, because these are queries that people have all the time and are very legitimate. And if there's something that you've read that you're not sure about, then please do go back and query it. The other thing that I'd like to promote really is something called the NHS app. So I don't know if people have heard about that, but there's an app that you can download if you have a smartphone called the NHS app. And your practice can give you the codes that you need to activate it. But this enables a number of really key things that people find helpful. So one is that it allows you to book appointments with your surgery. 2 is it allows you to order your prescriptions just by using the app. And the third thing is that, again, if you request it, the practice can let you have access to viewing your results if you want to. So again, that's another nifty way, if you're up for it, to sort of see when your blood results are back, because as soon as your GP has seen them and put a comment on whether they're normal or whether you need to come in and have a further conversation, you can actually see that on the app, and it saves you the job of having to ring up.
Okay, thanks very much, Dominic. I'll take one more question from Steve. Then what we'll do, we'll hand over for to Chris for the final comments before we finish. So Steve, over to you.
Just one comment first upon what Dominic's just said. That is, not all practices actually do allow you to book appointments or show you their results. But the other thing I wanted to ask about was, and it's gone out of my head.
Well, I'll come back to you and then you'll remember it. So you're
right.
I
know what it was. While I remember, you said that patients are offered telephone, face-to-face, or video appointments. The last appointment I had was telephone only. Was that aberrant or what?
No. So what I'm meaning is that the offer is made dependent on the need. So and that has to sort of be agreed between yourselves and the practice. So clearly we're wanting to keep footfall in practices to the absolute minimum. So if it can be sorted out over the phone, or if it can be sorted out on a video consultation, that benefits the whole system, and that would be what we would be encouraging. But if there is a necessity because a certain examination needs to be done, or somebody's hearing impairment is so severe that they're just never going to manage on the phone, well, then that is a good reason to agree to have a face-to-face appointment. So some of it would be, you know, your preference if there's a good reason, and some of it would be the clinician asking you because it's the only way to do it. But it's not that there's, you know, I don't want to mislead people in saying that there's a free range of choice at this. We've got to sort of offer different options depending on what we're trying to manage.
Okay, thank you very much, Dominic. Okay, I'm just conscious of the fact that it's now 2 minutes past 4, and I know we were due to finish at 4 o'clock. Chris, can I pass over to you for any final comments?
Yes, that's fine. Neil, thank you for taking over the chair while I have to go off to do something else. Really, just to say, I think it's been a really fruitful meeting. I hope everybody else has felt the same. I was going to ask for comments about how it's felt today, but I'll ask you just to put them in your evaluations, please, in view of the time we're at now. And just to say that our next meeting is on the 7th of December. We'll be using the same methodology as we've used today, and the last time I had a meeting. On the screen, it shows you some of the areas we're potentially going to be exploring at that meeting, just so you're aware of what we'll be looking at in the future. And I would just like to close the meeting at that point, if that's okay with everybody. Thank you for your participation. It's been really helpful. We've had some really good questions, and we would be keen to, obviously continue working using this in the future, rather than having the meetings just stood down completely. You can see there as well about the opportunities you have to complete the Survey Monkey, and we do again ask you to do that and give us the feedback that we need. And the final word on the screen there is to stay safe, and we have to all stay safe and abide by the new ways of work and new ways of living, and social distancing, hand hygiene, face covering, and all the rest of it. So take care, everybody, and I'll see you all in December, if not before.
Thank you.
Thank you. Bye now.
Thanks, everyone.